І я відвідував Україну з робочою групою, коли ми оцінювали, що робити в перші години після катастрофи. І також був в мене контакт з українськими колегами у рамках конференції в листопаді. І також був ряд вебінарів із теми, власне, виживання у бойових операціях. Відповідно, сподіваюся, що перекладач попросить вимкнути ті мікрофони, які не у доповідачів. І, відповідно, я зможу поділитися досвідом із виступів. У Сомалі в 93-му році, коли я спілкувався із солдатами, я був дуже здивований. Як військовий психолог, наскільки солдати готові були стріляти у когось, але тільки на початку. А після першого досвіду, коли вони стріляють у когось, вони мені сказали, так дивно, коли дивишся фільм якийсь, там, якщо в людину ти вистрілив, то людина відлетіла на 3 метри. А в реальності, якщо людину стріляєш, людина падає на коліна, падає кудись у бік, і це зовсім не так, як у кіно. І також молоді солдати, вони вели записи.
So they kept some kind of a record, and within the organization, there was a split up between those who already shot someone, those who already had real combat experience, and those who didn't. Now, Somalia was also one of these operations in which a lot of Western troops were faced with not only the adversity of war, but also the misconduct of their own troops. There had been troubles within our Belgian not firefighters, our Belgian light fighters, so the paratroopers. There had been trouble with the 3rd Canadian Para-Battalion. There had been Italian soldiers who misconducted themselves. And for me, this was the beginning of trying to understand how war always leads to some kind of norms transgression. And it's very scaring if you consider that each one of us has the capacity to turn into a beast. And how difficult it is to keep on track with normal norms and values. I will share my screen and go to a presentation which I named the survivability in combat, from individual rationality to collective irrationality. So if you look at the battlefield, it's normal that soldiers on the battlefield are confronted with fear of dying, but not necessarily fear of dying. For young leaders, this also becomes fear of making wrong decisions. Now, the fear is necessary in order to mobilize the resources which are necessary for survival. And in fact, these survival reactions, basically, we have 2 of them, stimulation and inhibition. It's not so difficult. It's some kind of autonomic, instinctive, and also automatic behavior. A behavior depending on the animal brain of the human being, but also influenced by the level and the type of training. I remember the problems we had with well-trained commandos and paratroopers when we send them into peacekeeping, because they were simply not fit for peacekeeping. They were trained in an offensive way. The stimulation response, the body calls on its resources to face danger, and this also gives way to what we could call, like as military psychologists could call this dissociative behavior, dissociation. In a lot of cases, if you look at the behavior of heroes, a lot of the behavior of heroes is based on dissociative behavior. Then there is the inhibition, which slows down the individual in his approach to risk, but also slows down the survival reactions of soldiers. Now, each of these reactions, inhibition, both inhibition and stimulation, can take a normal, but also an aggravated form when the terror quantity is exceeded. This is something we know from our clinical practice, and we know it from the window of tolerance concept, where we all have that kind of window. When we stay within the window, we stay within normal integrative behavior. When we exceed the limits of the window of tolerance, we get into hyperarousal. That might mean some kinds of panic, flight response. Also panic fight. It's well known that in a combat, most soldiers who shoot don't even aim a target, but they just shoot. They shoot, often they shoot out of reaction. It's also some kind of common knowledge you have. I've been an infantry officer myself, and I remember when we had exercises with real life ammunition, that it was very dangerous in certain moments. When someone started firing, everyone started firing. So it's a very contagious behavior. Fear is contagious, activation is contagious, but also slowing down is contagious. And sometimes this leads into a total immobility of a whole group of people. You might also leave your window of tolerance into the hypoarousal condition. And at that moment, there is a collapse of all your defense systems. Now, what's interesting, if you look at the beginning of an operation or the beginning of a war, like this has been the case in this war in Ukraine, at the beginning, there is some kind of formal organization. So there is the organigram of a military unit. Now, this organigram in combat situations is very quickly replaced by some kind of informal organization table. Now, what also is interesting is that the troop splits up into active fighters and passive fighters. What makes people go into active fighting? A number of variables. Quality of command and leadership, certainly. By the infantry, we always said lead by example. Group cohesion, we could also call this the esprit de corps. So the spirit of the mind, the spirit of the fighting spirit, the mental readiness. Also the hope of victory, and what is very important in this case, the correctness of the cause. So fighting for your country is one of the highest goods of the soldier. Confidence in the proper conduct of combat can be affected also by surprise, by the wear and tear of surprise. Common experiences, I took this from Carl Castro's series of studies. What are common combat experiences? Receiving incoming artillery, rocket, mortar fire, being ambushed, being shot at, being threatened, sometimes even being engaged into hand-to-hand combat, seeing injured, wounded, or dying enemies, or being responsible for the death of a non-combatant. Let's say the collateral damage. Knowing someone being seriously injured, in this case, it's an American study, so it was seeing seriously injured Americans. I received from Ukraine, from one of the Ukrainian colleagues I know very well in the meantime, I received a question, how can we work out some kind of immediate support protocol when someone dies at the front and the comrades has to continue fighting? What can we do just to push the pause button and have some kind of a short ritual, standing together, doing something? And that's some kind of stabilization protocol I worked out and I send them, and I hope I will have some time to share it with you. Now there's also knowing someone, having someone you know really well become a casualty, having to help wounded people yourself, even in times where you feel helplessness or usefulness, having your body shot. So these are common experiences, and I think we've all seen the images and know that it's always difficult to know what's really going on and what's true or false, but I think that some images don't lie. Especially when I see our own journalists and war reporters go to certain zones, and when they tell us what they see, what they witness, I think we really don't need much more images to know what's going on. Seeing destroyed homes and villages, dead bodies, disarmed civilians, witnessing violence, shelling of villages and cities, people having to handle and uncover human remains. These are also the experiences our American friends had in both Afghanistan and Iraq. So we know what this can do with the human mind. Now, as I said, the actors of combat, the formal structure in the organization table is soon, once combat starts, superimposed by a psychological structure in which you have another hierarchy than the formal hierarchy. Those with most influence, you could call this also transformational leadership. Those with most influence are those who are most active in combat. So men are unequal in their capacity to fight. Even when they have the same training, it's only a minority who will fight. It's a minority who will make the change. But this minority can win in a proportion of 1 against 20. That's something very important to tell when you train people. So I retired from the armed forces now since the month of January, but I'm into training of special units and special police units. And that's always something which I share with the trainees, saying, if you believe in victory, victory could be probable. If you get captured, the very first thing to do is to remember that you have to keep the permanent will to escape. You need a permanent will to escape and to survive. And each occasion you get, you have to try it. So don't lose your will. Don't lose the fighting spirit. Don't lose hope. Always look in front of you. There is also what we call la zone de mort, the dead zone. And I call this, I compare this like some kind of a black hole which attracts, with in the proximity of the black hole, the laws of physics are changed. And in the proximity of that, the normal psychology also changes. That is a highly gravitational object that transforms people and people's lives. So to engage in a fight is to enter a struggle. You get into a struggle, into some kind of a bubble of violence, and into that bubble at a certain moment, you don't even feel fear anymore. The worst is to get out of it and to wake up from the nightmare. Fear on the battlefield is useful, but at a certain moment, you don't feel the fear anymore. And you fight for the one who's standing next to you. So we should teach unexperienced soldiers how to cope with the physiological and the psychological symptoms of combat stress. Into combat stress support, so immediate support in cases where colleagues, soldiers are in a state of combat shock, they should learn that the most important thing is to engage their friend who is in shock into a cognitive way of behaving, to start up the prefrontal cortex again. Because in these cases of shock, it's the sympathetic nervous system which takes over. This system is intended for exceptional business, mobilizes and directs the body's resources, takes precedence, over the system, parasympathetic nervous reactions. But the most important is to get someone out of a state of shock, and it's not so difficult. So again, the shock might be a stimulation shock, so someone who's getting out of control and going into a panic spiral, or someone who's getting into a stupor spiral, into inhibition. That's what I told you also. This has to do with what I told you from my own experiences from Somalia, the baptism of fire, the first confrontation with fire. Soldiers, unexperienced soldiers should be...
Це те, коли солдат вперше попадає в бій. До цього потрібно готувати бійців. Потрібно мати реальні очікування цієї першої зустрічі із жахом, тому що він може зашкалювати. Буває навіть так, що у солдата насторожений ентузіазм напередодні першого бою, і їхні очікування будуть дуже відрізнятися від справжнього досвіду бою, від справжньої реальності кровопролиття. Як сказав Пол Лантьє, він написав публікацію ще після Першої світової війни. Перша небезпека є невідомим. Ми тремтимо, ми пітніємо, наш мозок не може більше мислити логічно. Потім ми маємо розлічати. Ми використовуємо звук снаряду для того, щоб передбачувати, куди він впаде. Ми лише користуємося прихистком логічно. Ми пануємо над небезпекою. Небезпека більше над нами не панує. Кожного дня ми стаємо хоробрішими. Ми все стаємо хоробрішими. І ми все краще себе контролюємо в довгостроковій перспективі. Що це означає? З плином часу в бою ми стаємо хоробрішими, але травма буде на нас чекати після того, як бій закінчиться. Отже, недосвідчений боєць починає битися все більше і більше. Він вже краще знає щось про бій. Спочатку нічого не знає, у нього виробляються інстинкти, він же інстинктивно відслідковує різні звуки, запахи, запах хлору, газу, пороху. Він же знає, як користуватися стрілецькою зброєю, гранатами, гранатометами, вже не кажучи про автомат. І так він стає сумою досвідів. І є ще те, що називається центром О. Це центр уваги. Це така периферія навколо інформації. Центр, звідки береться інформація і автоматично обробляється. Коли людина читає газету і йде вулицею, автоматично обходячи перепони. Таке роблять солдати. Я думаю, центр О, на який я зважаю дуже часто, це така форма дисоціативної поведінки. Це травматична дисоціація. На початку боєць боїться снаряду, незважаючи на те, як далеко він впаде. А потім страх залишається лише в його корисній формі. Використання страху стає автоматичним і є стимулом для адаптивної поведінки. Навіть наші найдосвідченіші спецпризначенці, вони вже не можуть адаптуватися до мирного життя. У них є діагноз ПТСР, але вони все ще ефективно діють під час бою. Отже, новачки, вони бояться погано показати себе в першому бою. тому що є певні поняття соціального статусу в соціальній групі. Але більше досвідчені бійці, більш за все, бояться каліцтва. І цей страх керує їхніми діями. А щодо офіцерів? Вони бояться прийняти неправильне рішення, що призведе до втрати їхніх солдат. Призвичаювання – це не те саме, що психологічне підкріплення. Призвичаюватися означає, що призвичаюються рухи, реакції. Це означає, що душа солдата більше не страждає. Те, що ми отримуємо на технічному полю, ми втрачаємо в рамках нашої нервової системи. Поки війна триває, поки триває бій, все більше буде відчуватися втоми і зносу. Солдати будуть все більш втомленими. Британський офіцер, медик, він пройшов 2 світові війни. Він описував це як цикл пор природи. Він казав, що екіпаж бомбардувальника переживає літо, коли все йде за планом, коли вони впевнені, але завжди наступає осінь, наступає дистрес. І їхній цикл трохи відрізняється від циклу наземних військ. Скільки можна безперервно бути в бою? Є дослідження. За результатами, після 60 днів безперервних боїв у 98% тих, хто вижив, з'являються психологічні проблеми. Війна в Україні вже триває 3 місяці. Ви можете собі уявити, що у більшості бійців вже наступає нестабільний психічний стан. Для того, щоб йти вперед під вогнем, уникати небезпеки, потрібно витрачати дуже багато енергії. Через це індивід зазнає дуже сильного психологічного стресу. І після того потрібно переключитися. Це коли бій закінчується, небезпека не загрожується, вся система розвалюється, тому що їй потрібно відпочити. Отже, кінець бою – це означає не завжди полегшення. Це перехід в нову фазу, перехід скидання тиску. Дуже часто, що у солдат бувають нервові зриви після закінчення боїв і повне знесилення. І ми вже говорили про 2 реакції на виживання – стимуляція і гальмування. І що буває нормальна форма, то ускладнена форма. Буває так, що люди рвуться в бій, і вони не зважають ні на кого і ні на що. Вони рвуться в бій. І це така форма дисоційної поведінки. Буває так, що вони дуже відсторонені від емоцій. Бій як морфій. Він триває, і доти емоційні і психологічні реакції і небезпека можуть не відчуватися. Солдати відділяються від безпосередньої реальності, і що може призвести пізніше до нервового зриву. Поведінка, що підтримує під час бою. Я, знов-таки, звернувся до робот своїх колег, до дослідження, і цікаво, що солдати із досвідом бойовим дій, як правило, повідомляють про те, що їхній сержантський склад, як правило, не могли логічно думати в умовах стресу. Що це справді дуже залежить від поведінки командира. Непродуктивна поведінка під час бою Це залежить від досвіду бойових дій, те, наскільки ефективно вони. І рядові часто або дуже часто намагаються вислужитися перед тими, хто стоїть вище за ієрархією, і що не завжди добре для злагодженості дій в підрозділі. Загалом рядові повідомляють, що їхні сержанти вели себе хоробро. Якщо у вас є хоробрий та завзятий лідер, за ним підуть люди. Це так зване трансформаційне лідерство. Тобто актори будуть активні на полі бою, і за ними будуть йти люди. Що ж, мій час вийшов, я намагався дотримуватися регламенту. Чекаю на ваші запитання. Я сподіваюся, що якісь важливі висновки ви почули з моєї лекції.
Thank you, Eric. If you can close...
Еріку, дякуємо. Якщо можна, приберіть слайди, будь ласка, тоді ми будемо бачити всіх учасників. Модератором сесії відповіді будуть пан Джетлі з Канаді, я також буду модерувати. Доброго вечора, дякуємо, дуже актуальна доповідь. У мене є кілька коментарів, але можливо...
I mean, I'll kick it off if that's okay. Eric, one of the themes that comes up a lot for me, and I remember last time I was visiting Israel and sort of at the north near Lebanon, and for a lot of us, the difference between, and Somalia is a great example of sort of these expeditionary wars that we fight in countries like ours. We often go away, and I just know the stakes of failure or what happens if you make a mistake when you're protecting your loved ones that are a couple of miles or kilometers behind you. So how do you think this changes when you're actually fighting on your home front for your own country and your family is sort of counting on you, and I think it amps things up. If you have any thoughts on that, that would be great.
Well, I think that the most important difference is I once wrote a paper on this with Paul Bartone, who was a friend working for the United States Military Research Unit in Heidelberg in Germany. And we found out that in a lot of our troops, expeditionary forces, peacekeeping and peace enforcing troops, that they had a lot of difficulty in finding meaning for their mission.
Yeah.
Asking themselves, why do I do what I do? And we compared it to the paradigm in social psychology, the paradigm of Seligman. Seligman, who was shocking dogs, and when the dog had no escape, when the dog did not learn to have control of the adverse stimulus, he showed a learning deficit, an emotional deficit, and a physiological deficit.
Yeah.
So that's the paradigm of learned helplessness.
Yeah.
And that's what we also found in as a paradigm for explaining the behavior of our troops. When troops are living in difficult or terrible conditions, but they find meaning, that's the control over it. Then they continue to adapt, that's their mental escape. A lot of our troops had no mental escape. Let's say the Belgians who were sent for 4 months to Somalia, and then they left the country with a lot of casualties and with even 5 of our troops dying. And
Yeah.
they didn't find a meaning. But when you're fighting for your own family, for your freedom, for your country, the meaning is into the mission itself. You don't have to look for the meaning, and that's the mental escape you need in order to justify what you're doing.
Yeah, no, I think that's a great answer. And I think there, the other point about leadership, of course, sometimes leadership's challenge is to find meaning in places where people are struggling with that, and maybe when you're fighting in your own home, the finding the meaning of the combat may be more possible. Any other questions, comments, folks?
Yeah, there is a question from our Ukrainian colleague Orest Suvalo. So thank you, Eric, for your interesting presentation. From your experience, what are the must-have points to prevent disorders after returning from combat? in military and civil mental health system?
In the military, I think that we should look at the experiences with the decompression programs, not just release soldiers coming out of a war and release them into their villages or their families, but first keep them together for a certain moment. That's why we had in most NATO armies, we had these third location decompression programs in which, for example, troops from the French Foreign Legion coming back from Afghanistan first went to Cyprus, stayed there for 3 to 4 days, received some psychological and medical checkup, received some training in how to cope with your family, etc., etc. And there was first this adaptation to the civil and normal society, because when you come out of combat, don't underestimate this this permanent state in which you are on a functional aggressive level. So if you would engage soldiers coming back from combat and you would engage them in team sports and you make them play football with 2 teams against each other, they would kill you. They would kill each other in football. So that's why we never, in these decompression programs, we don't engage them in team sports in which there is challenge, because they continue to fight. So first there is the need to lowering this functional aggressive level, and then they should readapt to what is a normal environment with normal sleep and with without incoming mortar fire, etc. So the adaptation should not take place within their family. And I like the concept, the original concept of jihad, where the little jihad is war and the big jihad is the fight you lead with yourself after the war.
Thank you very much. And probably our next speaker might talk a bit about the prevention in a civil situation. But we have 2 questions. I will now read one in Ukrainian, and yeah, Rakesh, maybe you can check the English one.
Yeah.
Війна наразі не така, як була у
This war is not like the Second World War. Now, this is the war of the machines. The soldiers might not see each other. Artillery and aviations and drones are operating on the battlefield. Is there any research on how the soldiers feel? How do they fight fear in this case?
I didn't understand everything, Irina.
Okay, so this war is totally different. This is a war of machines. You know, people so warriors can even not see each other because they fight with artillery and weapons. And the question is there any studies what those soldiers might feel when they combat with weapons, and how to fight with fear in this situation?
It's a good question, because more and more the human is seen as a factor in a machine operational environment where the human is the decision-making factor. Even the human fighter is more and more seen as a platform, a carrier of systems, a system of systems. So you might think then war is going to lose its human face. No, because it gets difficult when the human operator sees the results of his actions. So I think that's an important feedback we have to provide when people are thinking that it's just systems shooting from a distance and we don't see the other. I think it's important to always have this feedback about what are we doing, even because we have to stick to our norms. We cannot all move with to this war morality in which we lose norms. So that's exactly what we also do with our fighter jet pilots when they have to bombard, when they have to shell certain positions. They have to know, what am I doing and what has been the result of what I have been doing. Now, the fear might be there when you don't see the other and you don't know what kind of weapon is going to hit you, but that's some kind of useful fear.
Thank you.
Thanks, Eric. There's a couple of questions in English, and I can sort of combine them, and it's what probably you and I have talked about over beer over the years. But so when people come home, what are the must-have points to prevent disorders from returning home? And the second question is, knowing that people are going to have difficulties, they may be reluctant to self-disclose information about trauma. How would we better get alliance with people that come home and have difficulties? I mean, and the idea of screening, proper diagnosis, care. So how do we get soldiers that are coming back struggling to sort of open up and disclose and seek the help that's needed? And you have 30 seconds to answer that very simple question.
Yeah, okay. Well, I think one of the most important things is to try not to see them only as heroes, because when you say you're all heroes, they will not disclose anything, because that's they will shut up.
Oh, we have lost Eric, I think. Yeah.
Hopefully he'll rejoin. I mean, I can start with that. I mean, Canada, US, many of our countries, I think it's multi-pronged. I think the idea of creating a culture in which psychological difficulties after trauma is a legitimate injury, right? I think if we create that paradigm, start that paradigm at the home front in training, in Canada, we sort of use the word operational stress injury to put the footing. If an IED blows up and people have concussions and people have missing limbs or they have PTSD, they have legitimate injuries, I think that's an important thing to expect. I think these can happen at the home front, they can happen in training, all of this stuff. So it really begins with a language. Leadership needs to understand this. And just like we have concussion awareness in sports, it's now courageous to take a knee if you've been injured in rugby or in football or this kind of thing. We create that same kind of cultural change. So it's not really the job of the health system, in my opinion, to go running around knocking on people. The whole culture of military needs to change. And I don't think people, if they hurt their shoulder, if they hurt their knee, they will go for care. It's the same kind of idea. So to put the psychological injuries on the same footing, I think screening, education, reducing stigma, all of those things are effective as well. But really, it's the cultural change, in my opinion, that needs to happen. And that's, and we all come from the culture, the country that we're in. So I think that in many ways, our countries have to change. And the chief warrant officer of one of our army bases close by said, 20 years ago, I thought the courageous person was the one that sucked it up. But now I see the courageous person is the one that puts their hand up and asks for help. So that cultural change, I think, is really important. That has to happen, within uniformed personnel. And I think, thankfully, I'm seeing it. I'm seeing it more and more in the younger generation. The stigma is going away and things, and people are not afraid to admit that they're stressed or they were doing things like that. And I think when Eric talks about the transformational leader, a good leader does a debrief after an operation and says, I was scared too, right? Like, and acknowledges that. So I think there's a piece of that. Hey, Eric, you're back. So we missed you. We just talked briefly about sort of the necessity of cultural change, really, to have people come forward. So I think that's it. And I wanted to ask sort of one other thing, and I think it's really, again, the challenge that lots of us have. I mean, in 1980, we coined the term post-traumatic stress. And that word post kind of implies, and for lots of people, it's after you've been raped or after you've had a car accident. But of course, with police, first responders, and military, there often isn't a post, right? There often isn't a post. The trauma is ongoing. And we have to somehow help to win the war. Think about all the literature that came out of World War I, the Pies Principle and all of this wasn't really about helping people not to feel sick. It was to keep the fighting effectiveness. So So I think we're almost talking about, instead of post-traumatic, we're almost talking about intertraumatic or ongoing traumatic stress and how we manage that while the war is going on. So I don't know if you have some thoughts on that, which is, again, I'm sure with the firefighters and people like that, you certainly have seen a lot of that over the years.
Yeah, you're right. The difference with the soldiers, police personnel, warriors in times of war is that they have to they need support, but also they need the closure of things and go to the next one. So you never take the time during your career, during active career, or during the operation. You should not take the time to go too deep into your emotions. You need to be helped, to get structured, to get counseling, to get tips. But once someone starts to ask questions, how do you feel about what you're doing? You're not able to do anymore what you have to do. And then there's the other aspect. So like before my battery went flat, just to end this sentence, as I was saying, don't make heroes of everyone, because when you look at them only from the position of the hero, they will not disclose, because you already rewarded them with medals. And in fact, you're saying, shut up, you're a hero, so it's okay, and keep the rest for yourself. So we should certainly also consider, and maybe that one might be one of the next hot topic talks, we should consider the handling of moral injuries.
Yeah.
Thank you. And I think we need to move forward, to our clinical case presentation. And afterwards, we can go back to this discussion and hear more ideas and hear more.
Thanks very much, Eric.
Expert opinion. And I'm glad to introduce, here we have Professor Ursano with us as well. This is really nice to have another expert with us. So please, Oleg Gukovsky, a psychiatrist and psychotherapist, body-oriented psychotherapist and volunteer, who will now present a clinical case and will state his requests afterwards. Thank you, Oleg.
Thank you very much for inviting me, and very short reflection to the last topic that was mentioned about heroes. Like I found out, like for myself, that when I see somebody dies on the war, like from soldiers, I stop writing glory to hero or something like this, but I am mentioning as a warrior. And I think this changing of definition from hero to warrior, it make it more grounded, and then family can get better support, because if you're already hero, like you are getting already the highest reward. So I'm totally agree with my previous speakers. And my case, what I want to represent, I think it partially connected about survivability. One little correction, I will talk not about military hospital, and this is the point. I will talk about civil hospital and our regional civil hospital. And this is the case because like several weeks ago, it was a request from one doctor in which department a lot of wounded soldiers came, and it happens in many departments in this hospital. So it was massive massive coming on wounded soldiers to the hospitals where did not have any kind of so massive experience with wounded soldiers. So, and this was a request from one wounded soldier who asked, I would like to have psychology support. So this, our project, let's say, social project started from the request from one soldier. So it was not top down, it was as a grassroots kind of movement. I will share my screens and I will try to follow several steps what we did during last several weeks, and I would like to stress some important points. And I really would like to get any feedback how it goes in international context in such kind of work. Okay, I think this one. No, sorry. Yeah. I think this one. Yeah. Can you see my slides?
Yeah.
Just to check. Okay, so the project is psychological support of wounded soldiers and cooperation between hospital and professional NGO. So I call it like this. And since 2014, I have like many years of experience working with soldiers and veterans, but mostly it was a work for homecoming. So I work mostly with veterans who finish some stage in their military life and come back to civilian life. And so yellow color, it was my main area of work. And with the full invasion, like I focused on the other parts of the warrior path. So it's pre-deployment, deployment, and I'm collecting different international experience and Ukrainian experience about effective programs of self-care and body care. And one moment it's about psychological support during hospital care. So in this presentation, I will try to follow some steps. It's about mission of our team, because I'm not the only one who is making this support. I am more in the role of project manager, but there is a very cool team of skilled professionals who are doing mostly operative work. So our mission, I think our mission is to support wounded soldiers while they are in the hospital and connect them to resources. And in this idea of decompression, it seems like we have now 70, if I'm correct, 78 days a day of the full invasion. So it's like beyond the limits of 60 days that Eric mentioned about participation in the like acute combat. And now these soldiers, if we can think in the terms of decompression, now these soldiers got decompression experience because of they are injured, and they because they moved to another side of the country and in a full peaceful region, and like our region was almost not attacked. Since that, like a lot of air sirens, but not really damage. And this is, in my opinion, also can create some issues about this huge contrast between combat field and civilian field. And the aim of our team was not so from the first time when we come to the hospital, we create a memorandum and agreement with the doctors and the head doctor, like we have our area of responsibility. It's about psychological support. It's about psychoeducation. It's about covering emotional needs and support into recovery. Because as I remember, Norman Sartorius said that there is no health without mental health. And this is our area of responsibility. But we are not putting diagnosis. We are not prescribing treatment. We are not making evaluation. So we are not affecting this sometimes very bureaucratic part of the job. So we are doing what is impossible to do in state institution when you have 1 or 2 psychologists for a whole hospital. We collect, like we gather 15 professionals, and even will be more. And we cover 7 departments. And there is strong points of our team, like so professionals with many years of experience, because war already goes for 8 years. And there are many professionals who gather a lot of experience. And we are part of professional association, so we have ethical code, and we are aware about the main principle in medicine and in psychology, not to harm. Noli nocere. We are open system and with clear boundaries, so memorandum is about that. And we, since the beginning, we create our system of support. So it's our team meetings, and tomorrow we will have next one. We invite several mentors, and we invite one supervisor who has a very big experience working with veterans and militaries in Kyiv and other cities. Another strong point, and I think this point is very underestimated. From my experience in Ukraine, it's a peer-to-peer support. So I have many years working together with veterans, helping veterans in their transition. And I believe that this pair, when you provide professional frame and you can give some methodological knowledge with experience of battle experience of veterans who create this strong connection as a role model, as the representative of the same culture. I think this combination it's probably most effective what I met. And I think this point is very underestimated. And of course, our focus on building up resources and mentorship, I already mentioned. So, and for example, about peer support, on the first meeting into a clinical ward, I invite one friend. He is veteran with high amputation. And when he came to the one department where guys were with some small shots, I would say small shots compared to his experience, I think it was already something. So he injured much more than these guys. And I think even this comparison can create better self-esteem, and they created very good bonding, very good connection. And yesterday I met with one veteran who was a gold medalist also on Invictus Games, Igor, and he also agreed about providing some support for wounded soldiers, for example, through any educational videos, because he also finished our biodynamic foundation and training. So he got some psychotherapeutic education, and I think it supports his knowledge of what is going on, what stages veterans will go through. And he is much more able, and yesterday he was very appreciated for these tools, body-oriented psychotherapy tools, because he can reflect better, he can survive better, and he can support himself better. I think good quality educational materials is important. And for example, by Wendy Waits from United States, I got very cool breathing technique, and good flyers is helpful. Despite professional counseling, I think it's very important to create more human interrelations and connections through good rituals. And one ritual that is popular in like my community, my friend veterans community, it's a tea ceremony. So you can see the picture of doctor who, and we create tea ceremony for neurosurgeons for 1 hour. So they got the smell, taste, and also the chemical importance of good quality tea, because it contains L-theanine. It contains very important amino acid. And we agreed that they will support our tea ceremonies with veterans, for example, militaries, for example, when they having dinner. And also very important to build intelligence and support intelligence. And when Eric was talking about talking squirrel, fire squirrel in previous lectures, one of the way to build the intelligence, there is reading books, and I connect with the project called Army Reads. So and they sent, I'm waiting, they sent several books about history, about military arts, and so on, so on. So people, when they are stuck in the hospital, they don't need to stuck to the phones. They can read and they can develop themselves. So no waste of time. Mentorship, a very important point, to find skilled mentor since the beginning. And mentor was talking about survival guilt, very cool tips, phantom pain, for example, when you can grieve with a soldier about the leg or arm, and he needs to go to the surgery and make an amputation. So you will not have phantom pain if you can really let go, if you can really grieve about your limb. International mentor about team building, about how to manage the process. And I think in this game, let's say, it's very important to find benefits for all players. So, and there are benefits for soldiers from this cooperation, for hospital, for psychologists, and it's important to be aware. And like some short recommendation for hospitals from our experience, probably there are much more, that invite teams, not separate professionals, invite functional teams. They can provide self-support also. So, and in this case, like when you have a war and like this social awareness rise, you can invite these teams free of cost. You don't need to spend money on teaching. You already got very skilled professionals who can make a work. Involve veterans and wounded veterans. Provide safe place. It would be nice if every department can create safe place, like separate room where counseling can be happen, and be open for new knowledge, because now it's very important to be open systems, to interdepend, and good to sign memorandum, of course, because it's create more clear boundaries. And I had some. Thank you very much for listening to that. I have some questions to Eric, and I think only first question would be like interesting, because other questions were mentioned. So about just national military traditions, I'm really curious. Thank you very much. Any question?
Thank you,
question
Oleg.
to me, or
thank you, Oleg. I don't think we would have time to question you, but maybe we have really several nice international experts that might share their recommendations, ideas, comments on what you have presented.
I will provide the written answer to the question. So he Oleg asked me.
That's great. Any other thoughts? I mean, so I'll kick off with a little thing. I know that, you know, Barbara Sano is on as well. I think the one thing, to go back to the hospital-based and to go back to this idea is, and I think part of transition is, you know, many of our countries try not to medicalize sort of what might be a normal thing, right? So soldiers coming back from war, I mean, since the time of the Romans. So we try as much as possible, at least in Canada, and I know I've talked to my other colleagues, of really leaving a lot of this stuff in the realm of leaders, in the realm of peers, in the realm of this, because, you know, as we know statistically, the vast majority of soldiers, even exposed to combat, even wounded, aren't going to develop PTSD. So part of my initial reaction would be, let's not medicalize something. Let's help people with the transition. Let's normalize it and clearly identify those that need care. And that's the second piece, is resources are always going to be limited. So if we try to do one-on-one therapy for everybody that's having some difficulties early on, we're not going to have this. And my question to you, I guess, would be, does this have to be strictly in the realm of psychology, or are there other professions, are there other chaplains, are there other people that can help people with this transition? So I'll just throw those few things out there, my immediate reaction, but thank you for your presentation.
Thank you, Rakesh. Is the Professor Ursano with us?
Yes, Irina, I joined late, so I only caught a bit of what I heard. I certainly agree with what Rakesh was saying, and Ola as well, and good to see you. And I only joined with Ola's presentation, but I would make two comments. One about, we have to remember that PTSD comes in many forms, as Rakesh was alluding to, in particular, including one that for which one recovers rapidly, acute forms of PTSD. So the idea of not burdening patients with something that they may think of as cancer, when in fact the probability of metabolizing, digesting the systems, the responses they had, in some ways, recovery from PTSD, if you think of it as a digestive process, and most people digest, metabolize the symptoms over time. Some don't and develop chronic problems. I also particularly like the focus on peer support and involvement in the hospital that Ola has presented. Then the second piece I would comment on, only because I caught the word hero that Ola was talking to, and I have no idea what was spoken about before him, but I would remind everyone that being called a hero is also a tremendous burden. We often see, we not uncommonly see the burden felt by heroes at times, including suicide, because being a hero, one carries tremendous expectations from the community in which one is in. And those expectations to always be right, to always be just, to not have any problems in one's life. And those are tremendously burdensome.
And
so
Bob,
I share Ole's concern about saying using it too liberally, in contrast to a great job.
Yeah, no, you'd be happy to hear that Eric sort of brought that point across about hero about at least 4 times during his talk. And I think we all completely agree with, let's not burden these young people with that sort of legacy, because that's gonna, bite them eventually. So we have to be careful of how you honor people and how you respect people and commemorate things without putting that burden of the word hero on people. I think that's exactly what we need to do.
Good to hear.
I see here a professional psychologist and teacher from Vinnytsia, Tatiana Alexandrovna Komar. And Tatiana, if you want to share your experience, I know that you work with veterans as well for a long time, maybe within a hospital. Maybe you can tell several words about your experience.
Дякую.
Thank you.
У мене досвід в основному був пов'язаний з тим, що до мене
Yes. The parents usually come to me. The soldiers' parents came to me. Their sons were in the hospital. My experience has been more in supporting. Even after these young men were discharged from hospitals and returned home, I'm still keeping in touch with them. It's even a bit of a pedagogical experience. We're planning their training, whether they want to enter some kind of training, etc., etc. I second the speaker's ideas, who said that the initial phase of the meeting with these young men were about support. They were wounded. It was the rehabilitation institutes. There were amputees. These were young men. And my addition, those people cope with traumas better if they have a family. Family support really helps. If they have wives, for instance, And naturally, in case those are young men who have no families, it's harder to work with them. They are clueless about their future. Another thing I noticed during the first phase of meeting these men is that they are willing to come back, because these are the boys who were shelled during the first days, and they said they didn't even have time to do proper fighting. They didn't have the opportunity to do that. They were amputees, and we told them it's a long journey on rehabilitation. They were still willing to use the prosthetics and to return to battlefield afterwards. Thank you. It was an extremely interesting lecture. The first lecture, the hero term really can be a burden. Thank you.
Thank you, дякую. And Олег Сазонтович, чи ви з нами на зв'язку? Я знаю. I'm sorry. Professor Чабан, are you with us? Can you please comment briefly?
Я з вами на зв'язку. Вітаю, колеги.
Yes, welcome, colleagues. There's an air raid siren in Kiev, but I am here. The talk was very interesting. I listened from the very beginning.
Мій тезка. Я противник стаціонарної допомоги. Кардинально противник, тому що дійсно більшість пацієнтів справляються зі своїми проблемами суто генетично. В них закладена біологічна програма життя, продовження життя. Але в доповіді Олега прозвучала класна річ, яку би я назвав не ідея, а ефект фреймінга. Від того, хто доповідає, хто подає цю інформацію, тому і довіряють, і вплив значно більший від довіри. Тому долучення тих, хто пройшов через війну або має великий досвід, являється ключовим. По роботі з цими пацієнтами тут у нас в Києві я побачив одну річ. По-перше, на них немає часу, по-друге, і в них немає часу. Вони швидко зникають з поля зору впливу психолога, психіатра, психотерапевта, будь-кого зв'язаного з mental health. І я зрозумів, що я можу вручити їм, зникають по різних причинах. Хтось в силу опору, хтось просто втікає з госпіталя знов на війну, хтось ще по якихось причинах, в когось коморбідні розлади, і його з одного відділення переводять в інші. От ми зараз почали співпрацювати з інститутом ЛОР, там багато баротравм і психотравматичних розладів. І для мене все це звелося до одного. Я повинен, не я особисто, а психотерапевт повинен закласти в голову цього пацієнта дорожню карту, психотерапевтичну дорожню карту. Якщо навіть зараз нічого немає, що робити, якщо? Це відрізняється від того, що Олег показав, психоосвіта, psychoeducation. Це різниця. Тому що там дуже багато правильних формальних речей. Люди читають і тут же забувають. А от говорити з ним дуже предметно, наприклад, навколо теми алкоголю, навколо теми агресії в сім'ї, і пояснювати, що обов'язково потрібно буде звернутися до будь-якого спеціаліста, психо, який вже скерує до правильного спеціаліста, як на мене, це більш важливо. Тому зараз не піти по даній моди і навіть політики. Раз війна, значить ПТСР. Раз війна, значить стресові розлади. Раз є автоматизм 60 днів, врахуйте транскультуральні особливості, багато якихось речей, які взагалі ще не вивчені. І я думаю, що Україна своїм досвідом багато чого дасть в загальне розуміння ПТСР, тому що дуже багато особливостей, надзвичайно багато, про які ми не уявляли. Наприклад, війна з народом, з яким ти розмовляєш практично однією мовою. Чи можна привести багато прикладів. Тому От оця ідея, яку б я доповнив до доповіді Олега, дорожня психотерапевтична карта на майбутнє. Зараз встановити одне – довіру і вручити цю карту в голову його пацієнта. Все. Більше нічого не потрібно робити. Якщо, звичайно, ви не провели скринінг, не побачили вже розлади, не провели клінічне інтерв'ю, не працюєте з флешбеками, травматичною пам'яттю і так далі, все те, що розвернеться в ПТСР. Ну, от те, що я хотів би доповнити. Поза всяким сумнівом, я погоджуюся, і це наш досвід роботи з сім'ями. Як більш ефективно, ніж робота лише з самим пацієнтом. Дякую.
Thank you very much for that. And I think...
Прекрасно дякуємо за ваші думки. І ми хочемо все ж таки завершити за графіком. Будемо трохи завершувати. І ще раз нагадаю, ПТСР розвивається не у всіх. І ПТСР – це результат травми та втрати. Варто пам'ятати. Щодо колег, що працюють в лікарнях, що потрібно допомагати людям справитися з травмою, це не
trauma-informed care amongst other professionals would be helpful as well. I want to thank everybody. I mean, my good friend and our good friend Eric Vermetten would normally be doing this role. He's on a flight right now, so he asked me to pinch in, and it's been an absolute pleasure. And I just, really want to thank Irina for keeping this fire going. We're all saddened, very saddened by the war, and when I see what's happening in Odessa, where I was in 2018, it really saddens me. But it is good, to find some comfort amongst each other as friends and try to support each other. So we'll see everybody. And Irina, who's on in 2 weeks? It's Stephen. Stephen, I think.
Yeah. In 2 weeks, we'll have Professor Stephen Hopful with a presentation on 5 essential elements after catastrophe or war.
Disaster.
After disaster, so please follow our news, and I see people still having questions. I see faces still willing to ask questions, so you can put them in a chat and we will take those questions and we will try to find way how to deliver you information afterwards.
But thank you very much, everybody.
Yeah, thank you very much. We will stop, and now I will post a link to our project into a chat, and you can follow next meetings on the page of ECNP Traumatic Stress Network.